Diabetes mellitus is quite common in the pediatric population. We do divide it into type 1 and type 2. Unfortunately, we're starting to see more type 2 diabetes in adolescents because of the increased numbers of children that are overweight now. Certainly with type 1, it's an autoimmune destruction. Sometimes it occurs after a mild cold or some kind of viral disease, and then the child starts to have progressive signs and symptoms. As you all know, that diabetes mellitus, especially type 1, there's no insulin over time. The patients then become hyperglycemic. Hyperglycemia leads to glucoseuria. Your renal threshold is about 200 or so, and so you will start to lose glucose in the urine. Water follows and other electrolytes, so patients start to get dehydrated and they start getting thirsty. So they start drinking more to try to keep up with this. So there's the first P, polyuria. The next thing that happens is, since insulin is not present and you can't get carbohydrate into the cell as an energy source, the patients are basically getting hungry and they will eat more. So you have polyphagia. Polyuria occurs because of the glucoseuria. So you have the three Ps, polyuria, polydipsia, and polyphagia, and they generally will have weight loss in spite of the fact that they're eating more. These patients also then revert for energy metabolism. Since they can't process carbohydrates, they start breaking down fats, and ketone bodies will be produced. They then lead to acidosis. Patients will then start developing Kussmaul respiration to compensate for this metabolic acidosis. Up to half of patients with type 1 diabetes mellitus, their initial presentation is diabetic ketoacidosis. We don't have to do a lot of glucose tolerance tests. These patients come in already with diabetic ketoacidosis. So there you have the three Ps. They can sometimes complain of abdominal pain. They can have vomiting, and up to half of them actually present with DKA. Patients who don't present in DKA, you have some diagnostic criteria, such as an impaired glucose tolerance test. Your fasting blood sugar is 110 to 126. It's already an impaired glucose tolerance test, or the 2-hour. I don't think that you're going to get asked too much of this part on pediatrics. It's going to be more of an adult question. The treatment is going to be insulin. For DKA, it's going to be IV fluids and insulin, and the management of type 1 diabetes otherwise is going to be insulin given exogenously, as well as diet, exercise, and monitoring, trying to keep a tight control. Remember, with diabetic ketoacidosis, and you can take these teaching points over to your step 3 exam, insulin must be started as soon as possible. The mainstay of therapy of diabetic ketoacidosis is going to be insulin and IV fluids. At no time should you stop the insulin. If the patient's glucose is dropping and you don't want them to get hypoglycemic, go ahead and add dextrose to the IV fluids, but do not stop the insulin, because these patients cannot provide their own and you'll get back in trouble again. Rehydration also helps to lower the blood glucose. You do not want to lower the blood glucose too quickly. You want to lower it about 100 an hour. Shifts in osmolarity can lead to cerebral edema. Also remember that the sodium is falsely low. The patient will present with a high blood sugar and the sodium will be low, and that's because the sodium, the total body sodium, is actually changed and it's hiding somewhere. For every 100 that your blood sugar is above normal, you are hiding 1.6 milliequivalents of sodium. So you can do the calculations and you can see that the actual sodium is not as low as you think it is. As you correct the acidosis, the ions shift, and you'll see that your sodium is correcting. If your sodium is not correcting, that means that you're giving too dilute a solution of fluid, or you're rehydrating much too quickly. Type 2 diabetes, again, is being seen more in children, and it's more of insulin resistance. So they don't necessarily need insulin as their treatment, although initially many times they will be started on insulin and not on oral hypoglycemic agents. It's associated with childhood obesity. It's a lot more insidious onset. They don't really present with DKA, and certainly key word there is acanthosis nigrans. That's going to be that dark pigmented areas, particularly in the flexural areas around the neck and the axillary region, and that's very indicative of type 2 diabetes mellitus, and we're seeing that more in children also, the acanthosis.